Dear colleagues and guests, it's my great pleasure to give my presentation of the development of liver tumor treatment and the clinical value of ablation. I'm from the Department of Hepatobiliary Surgery, the first affiliate hospital of the University of Science and Technology of China. I'm a surgeon. My topic contains two parts. The first is the Chinese clinical guidelines for the management of the hepatocellular carcinoma, and the second will be the development of the hepatocellular carcinoma based on our experience. This is the first part. As is well known, liver cancer is the fourth most common cause of the cancer-related deaths. In China, the annual incidence of the ACC is over 400,000, accounts for more than one half of the world. Particularly, there are 8 persons losing their lives because of the ACC in each 10 minutes, while hepatocellular carcinoma accounts for 75 to 85% of the primary liver cancer. 89% patients have reached the advanced stage as the first diagnosis, which results in missing the best time for surgical intervention of the ACC patient. According to the ACC progress, different academic groups staging the cause of the liver cancer and developed corresponding guidelines for disease management. In addition to BCLC guidelines, as we will know, based on local medical system and practice experience, the China liver cancer staging we call the CNLC system was established in 2017 and has been adopted ever since, and is also updated in 2019. The difference in the staging system and treatment allocations among the 3 guidelines are shown in these figures. Compared to the practice in the Western countries, more aggressive treatment modalities, including resection, transplantation, or TACE, are suggested for more progress HBV-related ACC in China. Europe and American Association for the Study of Liver Disease guidelines advocate bridging and downstaging where local regional therapies to increase the transplantation rate and decrease post-transplantation transplantation recurrence. TACE is combination with other regional therapies like ablation or with systematic therapies like sorafenib and levatinib are also encouraged in select patients in China. And the second part, I will introduce the development of the hepatocellular carcinoma based on our experience. There are 4 parts of my introduction. The first part is laparoscopic hepatectomy, and the second is a conventional therapy for liver cancer. The third is liver transplantation, and the last is microwave ablation. This is the first part, laparoscopic hepatectomy. Over the past 2 decades, with accumulation of experience, innovation of the techniques, and development of the instruments, the indications of laparoscopic liver resection has expanded and is almost similar to the open liver resection. Common indications for liver resection, including colorectal liver metastasis, benign tumors, and hepatocellular carcinomas, can all be performed in a laparoscopic approach with equivalent or superior outcomes compared with the open approach. From a techniques aspect, standard principles used in the open liver surgery that have been shown to induce the morbidity and mortality still apply during the laparoscopic approach. Sometimes we also use the robotic, such as low central venous pressure, use of the Pringle maneuver, and so on. And this is the system review is the largest review of the laparoscopic liver resection available to date, with over 9,000 cases published in the world literature. It confirms growing safety when performed in selected patients and by trained surgeons, and suggests that laparoscopic liver resection may offer improved patient short-term outcome compared with the open liver resection. It is also through laparoscopic versus open liver resections for colorectal metastasis trial. The research report the 30 days complications rate, resection margins, and cost effectiveness for patients randomly assigned to undergo either open or laparoscopic liver resection. In China, pure laparoscopic procedures occupied 88.5% of the reported cases. Hand assist and laparoscopic assist procedures were only 5.3%, and robotic assist was 6.1%. And among these procedures, left lateral segmentectomy and local resection were major procedures of laparoscopic liver resection, and hepatectomy occupied 15.6% of these reported cases. 60% of these cases were indicated for malignant liver lesions, and the 39% were indicated for benign lesions. The majority of these malignant cases was hepatocellular carcinoma. It occupied 77%. As you know, this is the common cancer in China for liver. The other malignancies include liver metastasis from the colorectal cancer, cholangiocarcinoma, and so on. Complications rates was 30.2% in China. The major complications was bile leak. The mortality rate was 0.06%, including 2 patients complicated with liver failure reported, and conversion rate was ranged from 0 to 12.3 in China. Varies mostly depends on the patient selection, types of procedure, and surgeon's operations. This is over the past decades. Our team has accumulated rich experience in laparoscopic liver resection. In addition to some conventional approach, intrafascial approach, extrafascial approach, ligament teres hepatic approach, we carry out a variety of special approach. And this is our experience. There show 2 radical hepatectomy. The left one is the left hepatectomy. We use the fluorescent laparoscopic. We use the intrafascial approach. And in the right, we show our colleagues the right hepatectomy. We use the 3D laparoscopic, and we also use the extrafascial approach. During the approach in the left hepatectomy, we just firstly occlude the left hepatic artery and left portal vein. Then we can see the demarcating lines. Then we mark it, and we follow these lines to do the liver resection. Also, at this time, we use the harmonic to do dissection. At the right side, we can see the right hepatectomy. We use the 3D laparoscopic. We use the Pringle maneuver. During the 2 procedures, The first things we just search for the middle hepatic vein, and then we follow the middle hepatic vein, go to the vena cava and the right and the middle hepatic vein. During the procedures for the hepatic vein, we use the clip and to the in the left. This is the Johnson & Johnson, you can see. And for the right, we also use the clamp to do this. It may be safe and quick. And at the end, we also use the clamp to do this. Sometimes we use the suture to finish with this. For the time, I will move to the next slides. This is the Ligamentum trees hepatic approach in the Mesohepatectomy. It's 6-9 years old, a negative HBV and ACV. Alpha fetoprotein is 1.68 ng per milliliter, and the CA19-9 and is normal. The child proof score is A child. For this one, we used the clockwise hepatectomy approach in the Mesohepatectomy. First, we dissect the ligament and use the ultrasound to detect the tumor. After that, we do the cystectomy, and then we do the dissection, the segment 4 to segment 2 and 3. You can see there's no occlusions, but there's no bleeding at all. The dissection was clearly, and we only use the harmonic, and we will try it quickly for the time. After this, we see the middle hepatic vein and the left hepatic vein. You use the ligated middle hepatic vein below the conjunction of the left hepatic vein to middle hepatic vein. After this, we transfer to the right part. And for the right part, we dissect some ligament of the segment 4. As you know, there's maybe 3 to 7 ligament of the segment 4. After this, we use the CUSA to detect the right ligament. You can see this is the ligament 5, 8, and 7, and 6. So we clamped the ligament 5 and 8. We see the demarcation line, then use the harmonic to do the dissection. We can from the foot to head. And in the upper weeks, we want to find the right hepatic vein, and we will follow the right hepatic vein to dissect the right part. So this is the good methods for the Mesohepatectomy. We call it clockwise. And we also do the segmentectomy for the segment 1, and this is the segment 4. And maybe for segment 1 is the best vision for the laparoscopic. For the time, I will move quickly. And this is the segmentectomy of segment 6. Firstly, we dissected the ligament. We use the CUSA to detect. And if you, before the operations, we do the 3D reconstruction to see where we can do the occlude. So for the time, we just move to the next slide. And this is the segmentectomy for segment 7. You can see under the ultrasound guide, we use the acupuncture to the ligament of the segment 7. We just inject endocrine, and you can see the fluorescency under the fluorescency laparoscopic. So follow this guide, we can do the segment 7 resection. We use the ultrasound to detect that's the tumor in the all in the segment 7. We make sure. After this, we can use the harmonic to do the dissection of the parenchyma of the liver. This is segment 7, and this is the first operation of the segment H. Use the Olympus 4K laparoscope, and this is 51 years female and held HPV infection, alpha-fetoprotein a little higher, and the CA is normal, and child proof is score HA, and we can see this is the tumor. This is the middle hepatic vein. This is the right hepatic vein. So firstly, we want to see the middle hepatic vein. We want to search the middle hepatic vein. After we search the middle hepatic vein, we want to see the HeLa of the segment H, and then we dissect it. After this, we want to see the right hepatic vein, and in the operations, you should do the dissection between the right hepatic vein and the middle hepatic vein, and the bottom is the ligament of the segment H. During the operations, we use the harmonic and the CUSA. We move to next step, and we also use some retroperitoneal approach and the transthoracic approach. You can see this is the retroperitoneal approach in the laparoscopic liver resections. We can see there's a tumor in the segment 7. So we firstly use the retroperitoneal approach to do this. Firstly, we dissected the fat of the right kidney, and we open the retroperitoneal. We can see the liver, and we dissected the liver, then use the harmonic to do the liver resection. After the liver resection, we just close the retroperitoneal, and you can see there's only 3 incisions, and in the formal of the abdomen, there's no incision at all. This is the first time in our hospital to do this operation. And the others is the transthoracic approach in the laparoscopic liver resection. We can see this a tumor, and these patients have total gastronectomy 2 years ago. And there's a new lesion, maybe the metastasis of the gastric cancer. So we think, could we use the transthoracic approach in liver resections? You can see we use only a 3 centimeters incision and use the single part to do these resections. And we can see we use the harmonic to do the dissection of the liver parenchyma. Then we take off the tumor. And after this, we close it and put a tube to drainage. So maybe it's the first time use the single port to do the transthoracic liver resection. This is the picture during the operations, and this is the incision, and this is some pictures during the operations. And we also have the multidisciplinary team construction for the colorectal cancer liver metastasis. We can we can discuss some complicated patients. And the next part I will introduce, for the time, introduce convention therapy for advanced hepatocellular carcinoma. The objective of the convention therapy for advanced HCC patients is to take unresected tumor to resectable, lead parallel resection to radical resection, not eligible for liver transplantation to meet the standard, ultimately to improve radical resection rate, reduce recurrence rate, and improve survival rate. The methods for convention therapy consist of the target therapy, immunotherapy, TACE, HAC, radiotherapy, and interventional surgery, and so on. Combined therapy is more efficient. And based on the local therapy, the convention rate for HCC patients was different. You can see this chart. Well, playing with the combined drugs, especially for atezolizumab and bevacizumab group, and pembrolizumab combined with lenvatinib, has reached 30% and 46% objective response rate respectively. According to the two China studies in combination with the TKI with PD-1 antibody, the convention rate for advanced liver cancer range from 18.3 to 42.4, and this result is encouraging. After 2 cycles of the treatment, the carcinous thrombosis in the main portal vein gradually disappeared, you can see. And this is the picture, and this is the 3 cases. And another methods to conventional hepatectomy is to increase the future liver remnant volume, including PVE, AL, PPS, and PVL. The results ranged from 63% to 97.8%, but accompanied with many disadvantages, including high recurrence and mortality rate, operation waiting for a long time with tumor progress. The first case is to increase the future liver volume applied with liver venous deprivations. One PVE include, we can see the video. This is the before the intervention, and we do the 3D reconstruction, and we do the liver venous deprivation work. It was first reported by French group. And after this, we can see the advantage of the LVD is the post-operative future liver volume and hepatic function recovers quickly, contracting the interval between 2 operations. The operation is less harmful than AL, PPS, and the incidence and mortality of the several complication was very low, incorporating Clavendino score. And after the LVD, we can see the lateral left lobe was increased and became larger than before. We do the calculate of the volume, and then we do the extend right 3 segmentectomy, third lobe resection. We only reserved the left lateral lobe. You can see this is the end of the right hepatic vein, this is the middle hepatic vein, and this is the left hepatic vein. We can see the tumor nearly pathological completely response. And after operations, we can see the liver perfusion is very good for that. We move to the liver transplantations. We know the liver transplantation in China originated in the late 1970s and developed rapidly at the beginning of the 21st century. Regardless of the number of the surgical cases, the scope of the indications, the surgical methods, and the difficulty of the surgical techniques and the several rates of the patients or grafts, and the indication of the complications, they have reached the international leading level, or the advanced level. We can see especially the widespread use of the organ donor after the death of the citizens in the recent years has promoted the healthy development of the liver transplantation in China. Many technological innovations with Chinese characters have been applied and have promoted the development of the international liver transplantation. And we use the split liver, living donor, right lobe liver transplantation, and the living donor, left lobe liver transplantation, and living donor left lateral segment transplantations. And we also do some special modalities for the liver transplantations. And we also do some pre-transplanted patients with the PD-1 antibodies. As you know, there's the first case report is a fatal hepatic necrosis after the liver lab as a bridge to liver transplant for HCC. But we do some pre-transplant patients with PD-1 antibodies. This is the first case, and it recovered very quickly. And this is the second case done by my team. And we also do some residual liver transplantations of the hemangioma hepatectomy. We take the reserved liver to do the transplantation for the children. The residual liver transplantation after hemangioma hepatectomy, this is the residual liver, and the perfusion is good, you see. And the last is about development of microwave ablations. As we all know, other colleagues will introduce focus on the microwave ablations. So I will just introduce a brief introduce. As we know, one important application is to treat patients who are not considered surgical candidates. For surgeons, we most of my time we just do the operation. Sometimes we also do some microwave ablation, including in this category of patients with inadequate liver remnant tolerance resection tumor, multinodularity unresectable lesions at difficult anatomical locations, or patients who decline resections. Previous microwave ablation was limited to treat small liver tumors, but with the improvement of the attending and treatment strategy, lesions 5 to 8 centimeters can also be effectively ablated. And the main finding of the study, this study is that microwave ablations was not more effective than radiofrequency ablations for the treatment for a hepatocellular carcinoma lesion 4 centimeters or smaller, with no difference between the two groups in the proportions of the lesion with local tumor progress after 2 years of follow-up. Safely rid of residue on ablated tumors at 1 month after the ablations. median time to progression and overall survival also did not differ between the two treatment groups. This is a control of the radio frequency ablation. And also, other colleagues will introduce the advantage and the limitations of the microwave ablations. I do not say much more words about it. And this is the microwave combined with the hepatic resections. We sometimes do this worse because we are surgeons. When microwave ablations was combined with hepatic resection, hepatectomy, and compared with other modality alone, complications and blood loss was significantly lower than the combined treatment. And this is the picture of our do the laparoscopic microwave ablations for some special position of the lesion. And this is the automatic fusion system imaging contributes to the ablation scope. And for the macro hepatocellular carcinoma, we use the MRI and ultrasound to fusion system imaging. And we also use the CT-guided microwave ablation for hepatocellular carcinoma proximity to the gallbladder. And the CT-guided microwave ablations for HCC proximity to the portal vein, and this is to the intestine to avoid the injury to the intestine. And we also use the CT-guided microwave for HCC to the top of the diaphragm. We can also Transthoracic to do this. And the last slide says the TACE plus the microwave ablations appear to have more advantage compared to the TACE in prolonged overall survival with satisfactory prognostic factors for time to progression in patients with solitary large multinodular ACCs. And this is the TACE plus the microwave ablations during the treatment. This is the last slides. I just introduced our experience of the liver resection, especially for the laparoscopic liver resections, and our innovation of the liver transplantations, and some work of the microwave ablations and microwave ablations plus the TACE, the surgery, and so on. Thank you for listening. Thank you for your attention. Thank you.